the liver, and how it is compressing upon. Now there is another important point which you need to understand. When we are doing the surgery on the right kidney, what happens usually? Because we usually we are working on these kidneys in certain situation when it's not been, we are not able to deal endoscopically. So now while working here, the costodiaphragmatic recess is very close. So this closeness of costodiaphragmatic recess, and there is not enough gap in between, just the fatty layers. So as a result, we accidentally make a rent into the pleural space. And now you can see suddenly the air starts bubbling in your surgical field. That is an indicator of you have ruptured, you have damage, you have caused a damage to the pleura. So usually this is not a, well, it's not a good thing, I agree, but there are easy, if you recognize it, you should be able to recognize it if you cause a problem. So what we do at the time of closure, we repair the pleura because the air entry is not that significant. We repair the pleura and we have the tube in the lungs and all that, so we can manage, but this has to be repaired. If we left it open, it's a big disaster. So this happens a lot, so please be reminded, right kidney, so closely related to costodiaphragmatic recess. And while operating on this, we can puncture. So a question can be generated in this relationship. So be careful to, like, if you are given option, if you are doing, a surgeon is doing surgery and suddenly what happens, so which structure is being opened up. So think. Now,
Above the left.
so left kidney.
Close to the
Left is not close to the pleura. Left is up. And left is not that. It's not causing that. So it's only for right. This issue is only for right, not for left. Unless someone is wild, he can do everything. Ah,
So where does the bubbling happen? The bubbling of air?
in your area of surgery,
The
in
blood.
your area where you are working, where you have opened up. Ayman, can you stop? Ali.
You mentioned that you put the needle and you puncture. Which day did you puncture exactly? Why is it bubbling during the surgery? I didn't get that.
My dear, when you rupture this here, when you damage it here, you don't put a needle, don't put anything. You are working here. You are mobilizing this kidney. You want to approach some part of the kidney. Either you are taking it out as one piece or you are working for some stone or something else. So this is very close. And you can barely able to differentiate. And while maneuvering, you suddenly notice that air starts bubbling through your work area. So that is an indication that you have entered into the pleural space. And you can see that structurally the costodiaphragmatic recess is so closely packed, so close to the upper pole of this kidney. So while we are operating on the right kidney, especially in the upper pole region, if someone has a tumor, we are removing it from there by open surgery, which nowadays we are not. So there we can cause a rent in this plane, because just you can see that who's there, only the diaphragm. And you have seen in the labs how thick is the diaphragm. It's just a sheet. So there is a probability. And that this picture explains this liver, why it is pushing down the right kidney. On the left side, we don't have this big, huge lobe of the liver, so there is no such thing existing on that side. Yes, Nasu? Now, this is again important. What are the structures who are related to the anterior surface of the kidney and posterior surface of the kidney? So anterior surface, we had the right and left kidney in front of you. Suprarenals are always there. Now, to the hilum of the right kidney, we have a structure here which is known as duodenum. You remember? Stomach on the left side, it moves across the midline reach to the right side, then it continues as duodenum, which turns and then come back and goes down. So duodenum, which part it will be? Most likely the second part. So second part of the duodenum is overlying this hilum of the kidney. Which kidney? Right one. So this is the duodenum, the second part. Well, if you don't know the which part, but at least you should be best at it, it's duodenum. And then, who is living within the sea of the duodenum? Pancreas. So there you can see the tail of the pancreas and some part of the body of the pancreas is going. So pancreas is overriding the hilum and the frontal middle segment of the left kidney. Please be clear for these concepts. So pancreas, its tail is being seen, evident, covering this part of the kidney. Now, who's this? Liver. Very good, because right kidney. And left kidney, who should be?
Stomach.
Very good. But who's this? Colic flexure or hepatic flexure. Where you have the ascending colon becomes transverse colon. That turning, which is under the liver, we call it hepatic flexure. You remember? Cecum, ascending colon. At one place it turns on right side. So that turning part is called hepatic flexure. So that is turning here. And now who's this? Descending. Very good. So splenic flexure. Because this transverse colon goes like this, it dips a bit, then it ascends, and then close to spleen, it again turns. So this turning is splenic flexure. Then it continues as descending. Now, who's this area?
Intestines.
Ileum. And who this should be? Very good. Mashallah, you guys are smart. And who's this?
Stomach.
And who's this guy?
Spleen.
What? Yeah, you're good at it, looking in the pictures and all. You have the presentation. Thank you. Now, there is the peritoneal coverings. So, this much part is not covered by the peritoneum because there we have structures who are covered by the peritoneum. And these are the bare areas. So there, because pancreas is living here. If there was no pancreas, then peritoneum was covering this part also. So it is going above to that. Yeah. So the pancreas is sitting above to the kidney. Here duodenum is sitting above to the kidney. Colon is sitting above to the kidney. Colon is sitting above to the kidney. Now, coming back posteriorly. The one who's down, always right. The one who's up is always left. Now, we learn that. 11th rib only for left, not for right. 12th rib for both. Right? Then we have, how's this? Diaphragm. Right? The most medial muscle. Psoas major. Then quadratus lumborum. And the outermost transversus abdominis. Good. And then what nerves are these? So under the 12th rib, so subcostal nerve. And these iliohypogastric and ilioinguinal. If you know this much and the previous one, at least you have done something for your exam. Because the posterior relations, anterior relation, we ask as MCQ, we ask as auscultation. So just revise it a bit and I'm sure you are done. So now this is what I was talking in my previous slide on the right kidney pleural cavity and all that. What happened, you know the reason. Now, the general orientation of the kidney. We know there is the diaphragm, there are the kidneys, suprarenals, aorta, inferior phrenic arteries, suprarenal arteries, middle one, renal, inferior suprarenal canal. And then we have celiac trunk,
Superior
superior
mesenteric,
mesenteric,
inferior vena
this is
cava.
the inferior vena cava.
Why is that?
Right renal vein is always small, left renal vein crosses the aorta under the superior. So this is a very important point again. There is always a MCQ for this part. No, full essay, long essay. Not more than an MCQ. Why this left renal vein is important? Because it receives left gonadal
Left
vein.
gonadal.
The right gonadal vein goes to inferior vena cava.
Left gonadal, left inferior.
So there you are looking at
Left suprarenal.
left suprarenal. Right? So that is the important landmarks here. Now, blood supply of the kidney. Oni has done a little bit in her presentation, I saw that. So let's start with the renal artery. It divides posterior segmental. It goes behind. Who this should be? Superior segmental or apical artery. Anterior segmental. Anterior superior. So it is on the upper portion, not inferior. Because if it's there, we can also call it anterior. And who's this? Anterior, inferior. Who's this? Inferior segmental. So now, after that, these are interlobar. They are between the lobes. We know this much part is the lobe of the kidney. So between the lobes, interlobar arteries. And now they are surrounding.
Arcuate.
Right? So they are arcuate arteries. And arcuate will become radiates.
Radiates.
So cortical radiates. I have not shown it here because this is enough. Clear? So this is the pattern. Now if someone's cortical thickness is gone, everything is gone. The nephron are not there. So this filtration is being stopped. Is this clear?
Yes.
Now who's this? Okay, let's see. Inferior suprarenal artery. And this is
Pelvic artery.
pelvic and ureteric branch. So when we talk of the blood supply of the ureter, we can say that renal artery also supply the pelvis and the upper ureter. Clear? Now this picture was used by Oni also. So you can see the pathway.
Doctor,
Hmm.
do you have segmental vein?
Obviously.
Because in diagram it's missing the segmental vein.
It's not that much prominent. Now come to these segments. What are the hello? Khushi's coming in. Let's come to the vascular segments. Guys, this arterial plan will be dealt by physiology people also. They will also be using this lobar and lobular and arcuate and all that thing. So now the segments are important. So anterior and posterior surface. So there are these imaginary lines. So they are giving us superior, anterior, inferior, and inferior surfaces anteriorly. And what do we have posteriorly? Superior, posterior, and inferior. And these are just overlaps. Now, this statement, please be reminded. Kidney starts its journey from the pelvis. Then it's ascending up. So its blood supply first is coming from common iliac artery. But During migration, a series of vessels form to supply it, so only to innovate again when the renal artery takes over this duty. So there are so many things. So that explains there are certain aberrant arteries. There are certain aberrant vessels which have been seen in the pathway. We have one of the cadaver with us where you can see some unusual artery. Except for renal artery, there are some arteries and some veins connected to the inferior pole, superior pole. So that explains the migration. As I said to you in the beginning from today's talk, that kidney is the structure who develops below and then it ascends up. And testis and ovary, they develop above and then they descend down. Clear? Please remember this point. And this statement explains all that. Now, how a kidney, you can see that the mesh of the vessels, arteries within a kidney, and you look at the pelvic calyceal system and then the beginning of the ureter. So this image is self-explanatory and you can understand how vascular could be in a kidney. You just touch it and it bleeds like a fountain. Because there's a severe high pressure and it's highly vascular organ. Kushir, what's wrong? Sheikh, there is something to laugh. Now, this is a very big question. This is a deceiving thing. People talk about avascular zone in the kidney. First I was showing you the vascularity, pattern of vascularity. Now I'm talking about avascular zone. Theoretically, they talk. On the posterior surface, there's a certain area. If you want to cut the kidney, go from that part. Go from that zone. And there are no vessels. So you can enter the kidney without causing any damage, without getting any bleeding. Believe you me, I have opened so many kidneys. I have seen people opening so many kidneys, but I have never come across, and we were searching for it, where is this exactly is? Well, theoretically it may be somewhere, but we yet to see. If anybody knows it, tell me. So there is no such thing.
Why do we teach?
No, I'm not teaching you, I'm just showing you. If someone tells you, don't get impressed, oh, we didn't know this. I have shown you the reality. From my own, maybe I missed that part. I don't take it like it's the ultimate or I know everything. But what I'm trying to bring up here, it's been documented theoretically that there is an avascular zone. But we struggled a lot to find this avascular zone and still not able to find it, where it is, where it lives. Where is my sleeping friend? Can you wake him up? Ella, you want to sleep? There is a sofa, there you have a pillow, there's a commode there, all toiletries, everything. Now, I told you in the beginning, remind me, these coverings of the kidney, and why these coverings of the kidneys are important. I said one complete cover is being provided by the capsule of the kidney. And these are the different grades of the kidney and what is happening. We know the trauma, accidents, some assault, some incidents, some accident can be a road traffic, history of fall, some other thing. But as a result, if someone has a blunt trauma and we have if we categorize trauma, we have blunt trauma and we have sharp trauma. So gunshot injuries, now it's more common nowadays. Before the matter was some, blunt objects and sticks and all those things, but now with the advances we have gunshots. So now with this type of traumas, then we can see, now there, grade 1, because we have to do, the grading tells us what level of injury is there, and every level of injury has its own pattern of treatment. If it is being categorized, so and so is suffering from grade 1 renal trauma of the left side, left kidney. So grade 1, it shows that there is accumulation of the blood, but it has been inside, it has been within the capsule, under the capsule of that kidney. So we can sleep on this kidney. Just keep this person relaxed, comfortable, advise him, don't do some active type of work, lie down, do rest for a week plus, and then things will be fine. Because this is organ confined. It's within the capsule. Even capsule has not been breached. The capsule has not been damaged. Yes, Kanan?
I just want to know if it's under the